All right, let's jump right in. Today, we're taking a deep dive into Prevotella corporis, a bacterium that really has a split personality. You see, it lives harmlessly inside most of us, right up until it doesn't. We're going to trace its story from being a quiet member of our microbiome to becoming a pretty serious pathogen. We'll cover how we spot it in the lab, how it actually causes disease, and, of course, how we fight back. Now, all the info we're covering today comes from a Gemini deep search, and you can find a link to the complete notebook with all the sources right down in the description. So, here's our roadmap. First, we'll get to know its two-faced nature. Then we'll head to the lab bench to get into the nitty-gritty of identification. After that, we'll see how it makes people sick, tackle the tough subject of antibiotic resistance, and finally, we'll look at the latest guidelines for treatment and prevention.
Okay, so let's get started with what makes Prevotella corporis so fascinating and, frankly, so challenging.
This is really the million-dollar question, isn't it? This bug is a totally normal resident in our mouth, our gut, and our urogenital tract. Most of the time, it's just minding its own business. But under the right, or I guess wrong, circumstances, it can completely switch gears from being a harmless neighbor to a serious troublemaker. And there's a perfect word for this: pathobiont. It's not some evil villain that's always out to get us. Nope, it's an opportunist. It just waits for a window of opportunity, like a break in our mucosa barriers or when our immune system is down, and then it seizes the chance to cause an infection.
So, how do we actually know when we're dealing with this particular opportunist? Well, that takes us to the lab bench. Let's look at where this organism came from and the tools we use to nail down its identity. The history here is actually pretty interesting. It started its life, taxonomically speaking, as a bacterioids. Then it got moved over to the Prevotella genus. And this isn't just some boring academic trivia. This constant state of taxonomic flux has very real, direct consequences for our modern diagnostic tools, which we're about to see.
And that history brings us to this everyday dilemma in the lab. On one hand, you've got MALDI-TOF mass spec. It's our go-to, it's fast, it's cheap, it's a real workhorse. But, and this is a big but, its accuracy is only as good as its reference library. If that library isn't kept up to date with all those taxonomic changes, you can easily get a misidentification. On the other hand, you have 16S rRNA sequencing. This is the gold standard. It gives you the definitive answer, but it's also slower and way more expensive. It really drives home why having updated databases and a solid workflow for those tricky IDs is just so critical for patient care.
Now, back to basics on the culture plate, there are some classic clues we look for. It's a gram-negative rod, and it's a strict anaerobe, so it's a little bit fussy and needs enriched media to grow. But the real telltale signs are the slow formation of a dark blackish pigment, and, even before that, a really distinct brick-red fluorescence when you hit it with a UV light. That fluorescence is a fantastic early clue that can give us a presumptive ID days before that pigment even starts to show up.
Okay, so we've got an ID from the lab. Now let's connect the dots. What is actually happening inside the patient? How does this pathobiont flip the switch from harmless bystander to active pathogen? This is really the core of its strategy. Prevotella corporis doesn't rely on some single super powerful toxin. Instead, its lipopolysaccharide, or LPS, kicks off a very specific immune cascade through a receptor called TLR2. This brings in a flood of neutrophils to the site of infection. But here's the brilliant, diabolical twist. The bacterium then sabotages those very neutrophils, making them useless. This creates a vicious cycle of chronic, ineffective inflammation that leads to tissue damage and the classic abscess formation we see.
And that inflammatory engine drives a whole range of diseases. Since it comes from our own flora, these infections are pretty much always polymicrobial. It brings its friends along for the party. And they pop up whenever Prevotella corporis ends up where it shouldn't be. We see it in urogenital infections, oral and head and neck infections, nasty aspiration pneumonias, and abscesses just about anywhere you can imagine.
Understanding the disease is one thing, but treating it, well, that's a whole other can of worms. And that brings us to the absolutely critical topic of antimicrobial resistance and the lab's role in guiding therapy.
The big headline here, without a doubt, is beta-lactamase production. It's almost a given with Prevotella corporis, which means your basic penicillins like amoxicillin are just not going to work on their own. We're also seeing a really worrying trend of rising clindamycin resistance. And while metronidazole resistance is still rare, it's definitely on our radar. And of course, being a gram-negative, it's naturally resistant to drugs like vancomycin and the aminoglycosides.
And this is exactly why standardized testing is so essential. This table from EUCAST gives us the official rules of the game. These breakpoints are how we translate a raw number from the lab, an MIC or a zone size, into a clinically meaningful result like susceptible or resistant. This is what directly informs the clinician's choice of antibiotic.
Okay, so we've got all this great data from the lab. How does that get translated into making a patient better at the bedside? When you look at international guidelines, like those from the IDSA, a couple of principles really stand out. Number one, above all else, is source control. You have to drain that abscess. You have to clean out that wound. Antibiotics alone are not going to solve the problem. And number two is using combination therapy. Metronidazole is a fantastic drug for anaerobes, but it has to be paired with something else to cover the aerobic bugs that are almost always in the mix. And that's exactly why those beta-lactam/beta-lactamase inhibitor combos are such a mainstay.
Let's look at a really practical example from the Dutch guidelines. They're very syndrome-based. So for something like a complicated skin infection, maybe an animal bite where you expect anaerobes, amoxicillin clavulinate is the recommended choice. But if you're dealing with a life-threatening intra-abdominal sepsis, the recommendations ramp up to much broader agents like piperacillin tazobactam or a powerful combo of ceftriaxone plus metronidazole.
Now, for kids, the treatment philosophy is pretty much the same, but the execution has to be absolutely precise. Dosing is always based on weight. The drugs are familiar, metronidazole, ampicillin sulbactam, but every single dose has to be meticulously calculated to make sure it's both safe and effective for that specific child.
All right, for our last section, let's zoom out. We've talked about treatment, but how do we stop these infections from happening in the first place?
Because these infections start with bacteria that are already part of us, prevention is all about bolstering our body's own defenses. That means things like good oral hygiene to keep the bacterial load down, proper wound care to keep things aerobic, and using targeted antibiotics before surgeries that are going to breach a mucosal barrier. And of course, a huge piece of this is good antimicrobial stewardship, so we don't disrupt the protective balance of our normal microbiota. Now, in the hospital setting, we're not so much worried about passing Prevotella corporis from one patient to another. That's not really how it works. But, and this is non-negotiable, the foundation of all infection prevention is standard precautions. We're talking about relentless hand hygiene, thorough environmental cleaning, and perfect aseptic technique. These are the basics that protect our patients from any and all healthcare-associated infections.
And on that note, we would genuinely love to hear from you all. Every lab, every hospital has its own hurdles and its own smart solutions. What are your best practices for tackling anaerobic infections? Go ahead and share your experience in the comments. We all get better when we share what we know.
So, to bring it all home, Prevotella corporis is just a perfect case study, isn't it? It highlights this constant dance between microbial evolution, our diagnostic technology, and our clinical strategies. It leaves us with a really critical question for the future. As these pathobionts continue to change and adapt, how are we going to adapt to stay one step ahead?
Hey, if you found this deep dive helpful, please hit that subscribe button for more explainers on all things clinical microbiology. And don't forget, the link to the full Gemini notebook with every single source is waiting for you in the description below. Thank you so much for watching.